Today we will be trying to just have a little bit of concept about neuromuscular diseases. Okay. Just to start with, what is usually how, if we just touch something hot, how how the message is gone from that place to the brain and our muscle is contracted. So what mechanism occurs? Okay. Because the message will be sent from the sensory system, and then like pain. This is not the topic for today, but I'm just trying to. So then there is one motor area in the brain, and then it is coming from the descending tracts in the spinal cord. Okay. And from the spinal cord, it is going through the peripheral nerves. Okay. And then there is neuromuscular junction, where neuromuscular transmission is occurring, and this it is excitation, contraction, coupling. Okay. And then the muscle contracts. So whatever diseases uh, are occurring, they will be either, for example, if something happens in the upper like brain, so it will be stroke, it can cause muscle weakness. Okay. And later on, like there may be some even contractures may occur later on. Okay. Then there may be spinal cord injury. Okay. Spinal cord injury, again there is acute loss of all functions, and then there will be, like, depending on the level where it is occurring, there will be motor loss. Okay. Then there is a disease for lower motor neurons, like GB syndrome. Okay. Again, there is a disease for motor neuron, that is polio. Okay. Because of poliovirus. And similarly,
Multiple
if we
sclerosis, motor neuron disease.
motor neuron disease. Okay. So then again, because of degeneration, if there is degeneration in brain or spinal cord, there is a disease which occurs. What is the name of that disease? Because of degeneration, multiple
Multiple
sclerosis.
sclerosis.
Multiple sclerosis. Okay. Uh, then, okay. There will be some problem if, for example, if you just move further, there may be some muscle weakness which occurs at the neuromuscular junction. Okay. So either it will be presynaptic. Okay. That will be Eaton myasthenic syndrome. Okay. And it will be either post-junctional, post-synaptic. So that will be myasthenia gravis. Okay. Then there is some degeneration of muscles, that is muscular dystrophies. Okay. So there is a big list of muscular dystrophies. Then there is another important disease which we discuss, is because of bacteria, Clostridium tetani, which is causing tetanus. And similarly, there is another of same group which is causing also weakness, which is Clostridium tetani and Clostridium botulism. Okay. Botulini, what is the name exactly? So this, if you want to understand, you have to understand, first of all, the pathway from the brain, and then spinal cord, and the motor nerves, and then neuromuscular junction. So if you want to understand, you should have a basic concept about it. Then there any other things related to muscle weakness? Some electrolyte imbalance?
Yes, periodic paralysis.
Yes, periodic
Hypertension.
paralysis. Which electrolytes are responsible for muscular weakness?
Potassium.
Potassium, calcium, magnesium. phosphate. Okay. So 4 electrolytes mainly are maybe responsible. Okay. Then there is another muscle weakness which is related to an anesthesia anesthetist working in ICU. That is ICU acquired muscle weakness. Okay. So that is if no other pathology is there, but in chronic ventilatory patient, muscle this failure to weaning occurs. Okay. So we label it as ICU acquired muscle weakness, and there is different types of it. So if you just think about it, that why muscle weakness is important to anesthetists. What problems, if you I sent a scenario in the morning that there is a baby with some unknown neuromuscular weakness. Okay. So if any patient, for example, is why you are worried? What things you can suspect as anesthetist? There will be related to bulbar weakness. Okay. There may be related to respiratory muscle weakness. Okay. So there may be some altered response to neuromuscular blocking agents. Okay. There may be some autonomic symptoms which are there in the form of swings of hemodynamics. Okay. So autonomic dysfunction. Okay. Similar, because of bulbar weakness, what will be the problem? Aspiration risk. Okay. Then at the same time, if there is chronic aspiration, there are chances of chronic chest infections. Chest infections. Okay. So with regard to sensitivity to neuromuscular, there may be a prolonged effect. Okay. Resistance. Then hyperkalemia. Okay. And a nightmare, which can also occur, malignant hyperthermia. Okay. It will not be, actually, this is not there in every patient. I'm just trying to give a concept that whenever there is word neuromuscular weakness comes, you have to rule out these things. Okay. There may be some involvement of autonomic, autoimmune, other autoimmune diseases. For example, myasthenia gravis is an autoimmune disease which is associated with other thyroid disease or carcinoids or other things, or any other autoimmune disease. So whenever the word autoimmune comes, so you will be thinking that there may be some immunosuppressants patient may be taking, and there may be some steroids. Can you mute yourself, please, all of you? Okay. 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 So this is how you should be thinking. Okay, just critical thinking, which you now, if for example we touch one by one according to the importance, what happens in myasthenia gravis?
Yes, sir, I have a question, please.
Yes, please.
Sir, you wrote a malignant hyperthermia. So, can we add a neuroleptic malignant syndrome also in the list, or
Of
is it a
course.
differential?
Actually, it is a neuroleptic malignant syndrome is associated with, just a second, it's not writing. What has happened? What is a neuromuscular neuroleptic malignant syndrome is actually differential diagnosis of malignant hyperthermia. Okay. And it is associated with antidepressants or antipsychotics.
Antipsychotic, yes, dopamine.
Okay. So yes, you're right. Okay. So
Cardiovascular complication also common
Yes,
patients.
yes. I will be I will be just touching it. Okay. So actually, the when we will be looking at, because I left it intentionally because it is associated with majority of the muscular dystrophies. Okay, muscular dystrophies like Duchenne. Okay, like and this one Becker's, and there are some other. So multi-systemic effects on the respiratory system, on cardiovascular system. Okay. So we will touch one by one. So if we just start from myasthenia gravis, what is the problem in myasthenia gravis?
Autoimmune antibodies will develop against the post-junctional receptors of acetylcholine.
Postsynaptic acetylcholine receptors. Okay. So what happens? There is less acetylcholine receptors. Okay. So it will result in weakness. Okay. Usually myasthenia gravis, again, we have discussed it, but we will just quickly that it will cause bulbar weakness. It will cause respiratory muscle weakness. It will cause ophthalmic symptoms. Okay. So the things which are important for anesthetists are like, because there is bulbar weakness, there is risk of aspiration. Okay. There is respiratory muscle weakness. So there are chances of post-operative complications. Okay. And these patients may be on number one, immunosuppressants, steroids. If the patient is on steroids, you have to you will have to consider the replacement, steroid replacement. Okay. And immunosuppressant will have multi-systemic effects, nephrotoxicity, renal, this one, liver problems, bone marrow. Okay. Liver, kidneys, and bone marrow suppression. Okay. So in addition to that, there will be altered response to neuromuscular blocking agents. Why? What we are giving anticholinergics. Okay. Anticholinergics, just like neostigmine, we are using, all anesthetists are using for neuromuscular reversal, because it will decrease the destruction of
Acetylcholine.
acetylcholine. Okay. So the competitiveness with the neuromuscular blockers are increased, and here, because there is the symptoms will improve with giving acetylcholine. So we are using pyridostigmine. Okay. So pyridostigmine or physostigmine, I also always forget.
Pyridostigmine.
Pyridostigmine, Amigra.
Okay, so pyridostigmine, it crosses the blood-brain barrier.
Sir, physostigmine crosses the blood-brain barrier.
Pyrido doesn't. Physo it does.
Yes.
Okay. I'm sorry. The things which people I remember which the thing which I forget, I always forget. So blood-brain barrier is not crossed by pyridostigmine. It is caused by physostigmine. And one of the factor for the suspected post-operative complication is disease duration.
Pyridostigmine does.
Disease duration more than
6 years.
6 years, and dose more than 750 milligram,
per day.
and
Per
some
day.
coexisting per day, coexisting COPD. What else? And vital capacity. Vital capacity less than 10 ml.
4 ml per
10 ml per kg.
Ain't it 4 ml per kg?
No, 4 ml is tidal. 4
Okay.
ml is
20, less than 20 or 15.
okay. So in these patients, whatever history you are taking, you have to rule out these things. Okay. because this will tell you that this patient has problem in post-operative period. Okay, so if they are asking you a question, you will be your answer should be very focused that this is an autoimmune disease. Their patient may be taking steroids, immunosuppressants, so there will be concerns related to it. There is chances of bulbar weakness, so aspiration risk will be there. And another which I am not developed in on, the neuromuscular blocking agent, suxamethonium. Why there is resistance? Can anyone explain?
Because the receptors are defective, so tetramethonium find no place to attack. So that's why they are
Yes, so because it's a depolarizing muscle relaxant, okay, so it needs receptors. And if you are giving higher dose, so there are chances of phase 2 block. Okay, phase 2 block, dual block or phase 2 block. And with the atracurium or this one, any other muscle relaxant, there is increased sensitivity. Okay, because it's a competitive antagonist. Okay, competitive antagonist, so it's sensitivity. So the muscle relaxant of choice in these patients will be cisatracurium. Okay, and even that may be used in 1/10 dose. Okay, and maybe you don't need to repeat it, and you have to do in addition to the standard neuromuscular monitoring. Okay, you need to do
Sir, why
monitoring.
is this atracurium?
Cisatracurium is metabolized in blood. Okay, it is like any other medication
also it
which
is
has.
short acting.
Sorry,
Also it is short acting, that's why.
short acting. It is metabolized in the blood, so there are no less chances of recuriorization. Okay, what is recuriorization?
And there will be no need to give reversal also.
Yes, Usman, if you can speak a little louder because your voice is not coming clear. Yes,
Okay,
Usman.
sir.
Actually, what happens?
Sir,
This is
I
another.
was saying, sir, am I clear, sir?
Yes, it's better now.
Yes, sir. I was saying also there will be no need for reversal if we are giving atracurium. So that's why it is also the reason that we give atracurium.
This is one reason, but actually, if you are suspecting any symptoms, you can give neostigmine. Okay, because the patient is already taking anticholinesterase, so you can use in because that's another topic, that whether you how you have to continue in because these medications are oral, am I right? So they may be converted to neostigmine, if I'm not wrong. By the way, in my 18 years career, it's my luck. I have never anesthetized a patient with myasthenia gravis. It's my luck. Okay. Anyways, so can anyone explain, this is concept for resident, junior resident. What is recuriorization? Yes, Tamur.
Sir, recuriorization, what I think is the occupation, the remaining receptors remain occupied with neuromuscular blocker effect. So there is a remaining paralysis.
Okay, so when we give reversal, what happens?
Residual effect, sir.
No, it's yes, residual effect, or because actually what happens when you give neostigmine, does it bind with atracurium? What it does, or rocuronium, what it does with rocuronium? Why we give it? Actually, it has nothing to do with the muscle relaxant. Muscle relaxant will be metabolized, like there will be initially when you give a dose of muscle relaxant, okay, there is high concentration in the blood, and then from high concentration to low concentration, it is from going from blood to neuromuscular junction. Okay, and similarly it is going to liver, so it is metabolized. Okay, and like any medication, so then when the blood levels decrease and you don't give any further dose, blood levels decrease. Okay, so gradually this is moving from the neuromuscular junctions back to blood, and so and there is more acetylcholine which is being done by neostigmine. Okay. So neostigmine is helping by increasing the acetylcholine. It has nothing to do with rocuronium. The other reversal which you use, Sugamedex, actually is totally different. So it binds with the steroid ring. Okay. So it can reverse preferably rocuronium and also vicuronium, which is also a steroid. Okay. So this is the difference. So that's why when we give neostigmine, why we mix, actually this is concept for junior residents. I will take 1 minute to explain, because majority of people I have asked this question, and some of the residents even don't know this thing. So why we add atropine or glycopyrrolate?
Yes, sir, to counter the cholinergic effects.
Sorry?
To counter the cholinergic effects of neostigmine.
To be very specific, is it cholinergic you should be saying, or you should be saying muscarinic?
Muscarinic.
Sir.
Okay, because acetylcholine has two effects, nicotinic and muscarinic. So nicotinic effects are on the NMJ. Okay, and muscarinic effects are all over the body, like mainly secretions and bradycardia. Okay, on the heart. So if you need to compare, Osman, don't you know, so you don't answer, let them answer. What about atropine versus glycopyrrolate? We should use, I'm sorry, we should use atropine or glycopyrrolate with neostigmine.
Yes, sir,
Glycopyrrolate.
Why?
So because the mechanism of action and duration of action matches with that of neostigmine.
To be very specific, you're right. Onset of action and duration of action, like they
Yes,
are pharmacologically more alike. Atropine is like active man, so its effect comes quickly and goes quickly. So sometimes this is one of the reason for recolonization. One of the reason for increased secretions because of neostigmine. Okay, so this is just an outskirt thing. Okay, so we will come back to myasthenia gravis. So in myasthenia gravis, you have to evaluate any like severity, and there are scoring system. I cannot discuss in this setting because I have to rush. Even I have wasted a lot of time in this up till now, but I'm just trying to quicken my discussion. Okay, so we have discussed the things. So myasthenia gravis patient, if it is coming for any other surgery, like they can ask you for cesarean section. So can you give spinal in this patient? Epidural, or you should give GA? How will you compare?
So it depends on the severity of the disease also. If
Okay.
a patient has respiratory muscle weakness, so the spinal anesthesia can also worsen it. We have to balance the risk versus benefit for
Very good.
both mode of anesthesia.
This versus benefits, because because some people will say that it is better to give spinal epidural, but whenever you are telling this thing, you have to explain this thing, that even you have to assess the severity, and if it is involving the respiratory muscle weakness, even with the spinal and epidural, when they are blocking because these patients may be dependent on the this one like when
Intercostal muscles.
intercostal muscle, then they are gone with the spinal epidural. So this will be a problem. This I wanted you to know. Okay, and for example, sometimes this myasthenia gravis patient will be presented for thymectomy. Okay, so there may be like if it is a mass, you have to deal in the same way like any mediastinal mass. Okay, mediastinal mass, and you will be suspecting like a superior vena cava syndrome. Okay, thoracic what do you say, thoracic inlet or outlet obstruction. Okay. And because there may be different approaches, they may be doing with VATS or they are doing it open. So there may be need of double lumen tube. So you have to discuss, in addition to whatever we have discussed, you have to mention about these things as well. Okay. So they may be doing with, they have to discuss what approach the surgeon is taking for thymectomy. Okay. So some more words they ask in to a number of people. What is ice pack test? Anyone knows about it? And what is tensilon test?
So tension test is when we give adifolium to the patient suspecting myasthenia gravis, so it gets improved, or if it is in the cholinergic process, it will get worse.
So you can mention in a better way that you have you can differentiate between cholinergic versus myasthenic gravis, myasthenic crisis with the tensilon test, and it should be done under supervised environment, because there may be bradycardia, cardiac arrest even. Okay, and there may be respiratory weakness. So this is with the adrophonium. And what about ice pack test?
So it's for assessing improvement in tosin, diplopia, and ocular myasthenia gravis.
Okay, so because when we put ice on the forehead, this on the eyes, okay, this anticholinesterase enzyme is inhibited and acetylcholine breakage is decreased, so some symptoms improve. Okay, so this the question which is asked to you, you never forget. I had no idea what is this bloody test, and our examiners are very happy to ask this question. I don't know what's the fun in teasing the already dead person as a student. Anyways, so you should be knowing about it. So I think we have covered it. There is another Eaton-Lambert. Okay, so in Eaton-Lambert there is presynaptic problem. Okay, presynaptic, and it is also has some autoimmune origin. There is release of acetylcholine will be problem because of calcium channels. Okay, and it is sensitive to both depolarizing, because no acetylcholine is released. There is no problem with the receptors. So there is sensitive to both neuromuscular blockers. And they ask some other, it is more common in males than females. There may be some other differences as well. It is associated with the lung CA and if I'm not wrong, small cell carcinoma. Am I right?
Yes, sir. Small cell carcinoma, paraneoplastic syndrome.
Paraneoplastic syndrome. Okay. So rest of the things will be alive.
That the symptoms doesn't improve if we give neostigmine to such patients. This is also a differentiating factor.
Okay. Okay, so these two diseases we have covered. Okay, what is GB syndrome? Ascending. Weakness. It has a number of variants. Okay, just a second.
So it's a demyelinating polyneuropathy.
It's a demyelinating polyneuropathy, which has
Mostly occurs secondary to any infection.
Chronic inflammatory demyelinating polyneuropathy.
well, it has different variants. Okay, I will just this is one is AIDP.
Sir, Assam, yes, sir, Assam, Asman,
Aman.
Miller-Fisher.
Miller-Fisher is with the ataxia. So you can just have remember the names, okay? And they can ask you a little bit, because majority of the things are the same, okay? They can ask you what are different variants, so you can name them. And what is usually, it is preceding by some infection, viral infection, either GIT or respiratory tract infection. They can ask you what are the various viruses. I think they have written here.
Yes, Coxsackie virus.
It will be
Campylobacter.
written here somewhere. Anyways, you should be knowing the possible infection preceding these symptoms, okay? And it's a clinical diagnosis actually, okay? The associated, in addition to what we have discussed, is actually here there will be a lot of autonomic dysfunction, okay? So this is actually the main problem in a GB syndrome, okay? Because even with the movement, patient can suddenly have serious swings in blood pressure, heart rate, arrhythmias, okay? And there may be need of these patients will be having the all nursing care. And they can ask you, when will you be intubating the patient? So what should be you saying? Actually, there is no specific thing for it. When you are expecting and the patient is deteriorating, you will intubate the patient. All the mechanical changes in the ABGs, you will be just like any indications for intubation. Am I right, Usman?
Yes, sir.
And in addition to general care, you see, this is the indicator there. Vital capacity of less than 1 liter maximum. Actually, this is not specific to GB syndrome, mind it. These are generally the same things which you can remember for any, if they have problem in the inspiratory or expiratory, and there is inability to cough, okay? The airway reflexes are, protective airway reflexes are going. So at that time, it is better to intubate the patient. And patient might, because the prolonged intubation, okay? We will be discussing ICU in our coming days. So I'm leaving this ICU part because this is the common things which you will be doing, okay? But your patient might be needing tracheostomy and then the general nursing care. There is no specific thing other than this. What you will be here, it is the this one, immunoglobulins, okay, plasmapheresis. What is the role of immunoglobulins, by the way? And what other diseases patient might need or improve with immunoglobulins?
Tetanus, snake bite.
Yes. Is it giving passive immunity or active immunity?
Passive.
Passive immunity. What is difference between active immunity? If something is activating the immune system, that is active immunity. And
Vaccination, like.
Yes, just like vaccination. So this is for passive immunity, like it is trying to just counteract with the disease pathogens, okay, or antibodies. So plasma exchange, it is like prone to it's similar sort of. I have never seen it, by the way, and I'm not doing ICU for a long time actually, because in Saudi Arabia ICU and anesthesia is separate. Has anyone done face like have you done this plasma exchange in ICU in Pakistan?
Yes, sir. In GB syndrome patients, we usually do, because immunoglobulins are costly. Plasma is less costly as compared to immunoglobulins. So for poor people, we recommend Plex.
Yes, but it can cause some hemodynamic problems and chances of
Yes,
infection.
definitely. It has got more side effects than immunoglobulins. Definitely, sir.
You will not be doing it an unstable patient, okay? So you see, like coagulopathy, overwhelming sepsis, hemodynamic instability, steroids will be used. And actually, this is rehabilitation. Thromboprophylaxis and general nursing care will be there in like any other patient. Okay. We will
A
discuss
part
it.
of these, we have to give multiple cycles of plasmapheresis. If we see that IVIG, we have to give a specific dose, but for plasma exchange, we have to do multiple cycles, and the antibodies has fallen down considerably.
Yes. Okay. So, okay. Usually in the CSF, there is more protein in this. When we do in GB syndrome, there is high protein. Okay. And there may be, actually, this is to rule out other causes, because usually it's a clinical diagnosis. Okay. And some of the types, there may be some antibodies are positive. Okay. And generalized septic markers, ESR, CRP may be raised, and some liver involvement is there. Okay. So when they ask about GB syndrome, they will be asking you what is GB syndrome, what are different types, what are the problems, challenges. So it is, you can say that the chances of aspiration, autonomic problem, respiratory failure. Okay. So this is how you will be answering question for GB syndrome. Okay. So now we will go to tetanus. What is tetanus? Tetanus is caused by Clostridium tetani. Okay. And there are two types of toxin which is producing. What is that? Tetanospasmin and tetanolysin.
Lysin.
Okay. So lysin is causing the lysis, and spasmin is entering and traveling through the nerves. And why there is rigidity in tetanus? Why there is a spasm? It should be weakness, am I right? So why there is stiffness?
Because there is disinhibition of the descending inhibitory pathways.
Yes, like the grandfather effect is finished. When grandfather effect is finished, so the muscles became crazy. Okay, so the inhibitory effect is lost. So when inhibitory effect is lost, so there is rigidity. So what are the trademark selling words for tetanus? Trismus,
Trismus, lockjaw, masseter, spasm, opisthotonus,
Opisthotonus,
rhizotonus, some
no,
words
Rhizus,
like that.
no, Rhizus,
Rhizus sardonicus, yes. Yes,
Okay.
yes.
So on a funny note, I wish that there is no senior one listening to this word. If you go to examiners, the face of examiners are Rhizus sardonicus. And when they ask the question, you become Trismus. Am I right? Okay. So they will be asking you the question in a similar fashion. Okay. So don't worry about it. Again, I repeat that the general nursing care is the same. Okay. For tetanus, for GB syndrome, or any respiratory problem in ICU, you will be giving the general care. You will be taking care of pressure sores, ulcers. Specifically in tetanus, you have to keep the patient in a isolation, in a way that any stimulus,
Cool, calm, sedated, yes.
cool, calm, sedated, even positioning can cause serious problem in these patients. Okay. So and actually, I tell you something, any exam, if they are asking you these classifications or severity, this is not to fail you. Actually, this is just to make test your nerves, by the way. And another thing is that you just have to tell the rationale rather than cramming the grades. So just like muscle rigidity, muscle spasm, autonomic instability, okay. Rhizus sardonicus, typical facial expressions, okay. So truncal spasm will cause this opisthotonus, okay. And there may be a problem in ventilation, tracheostomy will be needed. And management, there is no specific, antibiotics are given, immunoglobulins are also given. Antibiotics usually are penicillins and metronidazole, am I right? And surgical debridement will also be done. Antibiotics usually are metronidazole, okay. And penicillin, they have not written here, yes, use of, this is something new, okay. Just a second. Use of penicillin is proven in proven cases of tetanus remains controversial. This is something new for me as well, okay. And for control, this autonomic instability, symptomatic. You might need to have some antiarrhythmics, you might need to have beta blockers, you might need to have like according to the response, okay. And pain control will also be needed. There may be need of magnesium here as well. And there is another medication, it is called Baclofen, okay. It is also used for the rigidity. I don't know if it is written here or not. Baclofen is being used for treating the muscle rigidity. Is there any role of dantrolene? Yes, the Baclofen is written. Baclofen is a structural analog of GABA. So Baclofen is being used, okay. In tetanus, because of specific muscle spasm, rhabdomyolysis can also. Okay, rhabdomyolysis, myoglobin renal failure. Whenever this word come, so you should be, the other second words will be that thing. Okay. So in tetanus, they can ask you about immunization as well. So anyone, any words about, a few words about immunization? You have to give both active and passive immunity. Okay. So the tetanus toxide which we give, is it active immunity or passive immunity?
It is active immunity.
Active immunity, okay. And anti-tetanus serum is passive immunity.
This is passive.
Passive immunity, okay. So they can ask you.
I think 50%. I think there is a specific way of giving 50%. We give to the wound, and then 50% on the other side of your arm. Like you should not give both toxide and immunoglobulin on the same arm. You have to give on the other arm. This question is asked in exam.
Okay, I have no idea about it, but they can ask you about this question. Okay, so they will be asking what is tetanus, what are the features, how it occurs, this tetanospasmin, tetanolysin, and I forgot to tell incubation period. There is some injury, and then there may be some incubation period, 3 to 21 days, average 7 days, and then manifestation can occur. Okay, so I think we will have to have 2 sessions. It will not be, I'm getting tired actually. So actually, you know what we will do, that we will have to take another, I was very low in energy today. So I will do another session for rest of the thing, this polio and multiple sclerosis and neuromuscular dystrophies. Okay. Tomorrow, and I so because I was thinking to finish it in one session, but I think it will not be possible. Rather, but I will do that. We will do the topic of this general ICU care together with this topic. Okay. So I will stop here. I hope you understand something, because you know actually my point of view and my way is that you people are mature enough. You just need a guideline how to approach a topic in for people who are appearing in the oral part, how to, what can be the possible questions, and how you have to answer. Okay. And the people who are preparing for the written part, remember one thing, that actually if you have the clear concept, it will be easier for you to answer the question, even if they are asking in the MCQs. Okay. I remember there was a question on Miller-Fisher syndrome. I had no idea at that time, because we don't have these articles, but I think this word was taken by examiner by some, I think most probably this GB syndrome article. Okay. So we will continue our discussion on this muscle weakness, because there are so many things are left. Actually, I couldn't do it. I tried to be fast, but I couldn't do it. Okay, so we will do tomorrow the rest part of the muscle diseases. Any questions? Dr. Anika, are you exam candidate or you're resident?
Say exam candidate.
Okay. Okay, so I hope you got some advantage, and okay, see you tomorrow, inshallah. Assalamu alaikum.